Okay, good afternoon, everyone. We're going to get started with the webinar. So again, I want to remind people to please mute your phones. We are recording this. And so welcome to our webinar, Shifting Landscapes, Emergent Workforce, Maximizing the DIS Skill Set for Your Program. This webinar is part of the California State Office of AIDS Prevention Webinar Series. My name is Linda DeSantis, and I'm a program manager with the California Prevention Training Center in Oakland, and I'll be hosting today's webinar. This webinar is sponsored by the California State Office of AIDS Prevention Branch in collaboration with the Pacific AIDS Education and Training Center and the California Prevention Training Center. We also have the Curry International TB Training Center helping us produce the webinar with their technical assistance today. All three training centers have a national and international focus, providing training and technical assistance to public health departments, CBOs, and private health care settings to increase capacity to the public health workforce in HIV, STD, and TB programs. We've collaborated for many years and find that our training audiences cross over, so it's good to work together on this. Before we start with today's presentation, I want to cover a few housekeeping items. As we've mentioned, we're recording this for future reference. So all the noise gets recorded, which is why we're asking you to mute your phones. The link to the webinar will be sent out to all of those who have registered. It will also be available on the CAPTC and the PAETC websites for review or for people who were not able to attend today. We will be using the chat box to take questions. So we'll ask that you please type in your questions as they come. We'll address questions at the end of the session, and any questions that we're not able to cover in our time frame will be collected and will be sent out to all who have registered. So just for a little practice, I would like to ask anyone who is logged in and watching with a group of coworkers or another person to type the number of people that you have with you in your room in the chat box. This is going to help give us a better idea of the reach of our webinar. Great. So it looks like many of you are watching with another or several others. Thank you for doing that. If you should need assistance during the webinar, you can raise your hand, you'll see, by going to the icon above the slides, and we will check in with you via private chat to see how we can help you so as to not interrupt the presentation. If you're experiencing any delay in the slides advancing or audio during the webinar, it's likely due to a slow network connection at your setting, so please be patient. Usually the audio is fine even if the slides do not advance in sync, and there's often nothing we can do on our end to support that. This webinar series, which continues through February, will address current topics relevant to HIV, STD prevention programs. Today's webinar highlights the important and ever-expanding role of DIS in HIV prevention efforts. We'll learn how DIS are important in all activities within the continuum of care and the skills that they can offer and provide. So presenting today, we have Romney Nyman, who is a Center for Disease Control Public Health Advisor assigned to the California Department of Public Health STD Control Branch, who is the Assistant Branch Chief. Romney has 23 years of experience working in STD and HIV programs, beginning her career as a disease intervention specialist assigned to Chicago and then Philadelphia. Over the past 20 years, Romney has held a number of different positions, including supervisor in the Long Beach CDC DIS Training Center, managed care liaison, and chief of the program development section. In her current role, she works closely with local health jurisdictions in program planning and prioritization of STD HIV disease intervention activities. She acts as the liaison to the CDPH Office of AIDS, fostering collaboration and integration in state-level policy and program. She has been instrumental in the development of a number of workforce development initiatives, including the Disease Intervention Specialist Fellowship Program and HIV Partner Services Mentorship Program, and has served as the CDC Field Staff Representative on the National DIS Certification Project. Also presenting today is Wanda Jackson, who is a partner and program support service trainer and TA specialist with the California Prevention and Disease Intervention Training Center. Wanda has extensive background in the field of STD HIV prevention. She has worked as a disease intervention specialist, public health investigator, and frontline supervisor. Wanda maintains her connection to frontline work by assisting local disease intervention specialists in contacting, locating, and interviewing clients to prevent the spread of STDs and HIV. Wanda is known nationally as a passport to partner services trainer and is committed to providing quality skills-based partner and support services training to aid in intervening and preventing the spread of STD, HIV for healthcare professionals throughout the United States. I want to welcome both of you, and Romney, we'll get started with you.
Thank you very much, Linda. Let me go ahead and forward these slides. What is a DIS? This definition was created during the second phase of the National DIS Certification Project. And you will find this definition as well as other materials published on the Public Health Accreditation Board website as they took the lead in convening the second phase of the project. A DIS is a non-licensed public health professional with specialty expertise, specifically in client-centered interviewing, enhanced surveillance, contact tracing or partner services, field investigation, and they do a good deal of collaboration with medical providers to ensure patient evaluation and treatment. And they are also a resource that's been tapped into for outbreak investigation and emergency. Disease intervention specialists are an essential part of the public health workforce. And their job is to prevent disease complications and intervene in the spread of disease. Overall, working to improve the health of local communities. In their public health application, disease intervention specialists routinely focus on HIV and STD partner services and TB contact tracing. Through the National DIS Certification Project, enumeration surveys were done. One by NACCHO, looking at the number of STD and HIV DIS nationwide. That number is around 1,600 DIS that work on STD and HIV. The National TB Controllers Association also did an enumeration survey and found approximately 550 DIS working on TB contact tracing and DOT. Also, through the DIS certification project, there was a job task analysis done where DIS throughout the nation were surveyed, and over 50% of those surveyed indicated that they were involved in outbreak response at the local level and emergency preparedness. Some of the larger response efforts that DIS has been associated with have been Ebola outbreaks, hurricane and other disaster relief, and HIV and STD outbreaks throughout the country. So are all DIS created equal? Is a DIS in California, the same as a DIS in Iowa, and the same as a DIS in Florida. And even within the same state, are all DIS created equal? Disease intervention specialists can be called a number of things. Communicable disease investigators, communicable disease representatives, disease intervention technician, public health associate, public health investigator, communicable disease specialist. Where they differ is in their disease focus. Some DIS focus only on STD, some only on HIV, some combine, some on tuberculosis, and some are focusing on all communicable disease. Assignments may also vary by their geographic location and structure of the government which they're assigned, whether it be at the state or the local level. Additionally, some differences may exist based upon what fund source they're sponsored through, as some DIS, like in Colorado, may be funded with STD, HIV prevention, and SAMHSA funding, and so they may do a broader range of activities than a DIS in another area that might just be funded with STD dollars. Additionally, the focus of their activities may vary based upon the morbidity within the jurisdiction, as well as the technological tools which are available to them. All nationwide, DIS have more in common with each other than they do apart. These core elements have been identified through a job task analysis that was conducted as part of the DIS certification process. Subject matter experts created a series of key task statements that were then sent out to DIS nationwide in the form of a survey. 495 DIS answered the survey, and they represented 40 states and Puerto Rico. These DIS were asked to rate each element based upon each task and knowledge statement based upon frequency, importance to their daily work. 98% of the tasks that were put forward in this survey were validated as important and frequently used, and 99% of the knowledge statements. The only statements that were excluded as part of this survey process as the DIS certification process moves forward were those that were TB specific around environmental assessment. What this means is that overall, nationwide, regardless of whether you're STD, TB, HIV, or which health jurisdiction you work in, state, local, DIS across the board have core competencies and core tasks and knowledge that they bring to the table. They may be called different names. STD uses terms such as referral for treatment or ensuring treatment. TB calls the same activity treatment completion, and HIV calls it linkage to care. But overall, these tasks are consistent, and they are a specialty expertise. How do these relate to HIV? Let's take a look at the intersections of DIS with the HIV continuum of care. Specifically, STD and TB DIS interact with clients that are at risk for HIV and can help to identify key populations. DIS can facilitate testing of key populations as well as linkage to care and re-engagement in care. And when STD and TB programs collaborate and get support from their HIV programs, together these programs can work to take steps towards getting to zero and increase the risk of HIV. As you can see in this slide, an individual diagnosed with rectal gonorrhea or chlamydia is 1 in 15 MSM who were diagnosed with rectal gonorrhea and chlamydia were diagnosed with HIV within a year. Additionally, individuals MSM who were diagnosed with primary and secondary syphilis were diagnosed with HIV within a year. So integration of STD and HIV is a significant opportunity for HIV prevention with this population. Looking at California and the STD morbidity that exists in California, unfortunately, California was ranked #1 among all states for the number of syphilis and gonorrhea cases in 2016. But what this does show is that there are great opportunities to identify individuals who may be at risk for HIV through STD work. Looking at the early syphilis cases in the California project area, we find HIV prevention opportunities, particularly with MSM. Looking at the cases and the bar graph that's in front of you, in 2016, 54% of the cases reported were among MSM. That would be the left bar. 5% of the cases reported were among men who have sex with men and women, 15% among men who have sex with women only, and 16% among females. The HIV prevention opportunities that present themselves here are really, if you look focusing specifically on MSM, 4% of the early syphilis cases were identified of the early syphilis cases were HIV positive and new HIV positive. There are opportunities there with those that are indicated in red for linkage to care and partner services so that their partners could be tested and potentially linked to PrEP or linked to care, whichever would be appropriate. There are also opportunities in green for those that are HIV positive and previous positive to assess their engagement in care and refer for re-engagement with those who have fallen out of care. Additionally, there are opportunities for partner services for those who are HIV positive, both newly and previous. And for those who are previously positive, possibly some may not have been ready to engage in partner services with their initial diagnosis. So the interface with them when they have a syphilis diagnosis offers an opportunity for HIV and syphilis partner services. There are additional opportunities again among those who are HIV negative who are diagnosed with syphilis. These individuals could be referred to for PrEP and also retested as relevant given the timing of their negative test. And additionally, for those who are unknown, and here with MSM, it's 10% who had unknown HIV status, what an opportunity for HIV testing and appropriate referral. To highlight, with syphilis diagnosis, there are opportunities for public health to interface with populations who are at risk that may not otherwise engage in HIV prevention. And this is particularly advantageous for identifying individuals for PrEP. With syphilis diagnosis in California, it provides particular opportunities to reach MSM of color, as African American males are 2 times as African American male syphilis rates are 2 times as high as rates among white males. And how does it really work to integrate services at the client level? Data sharing and record searching to confirm STD and HIV test and care status prior to the client interaction allows for more comprehensive and client-centered health care, and it allows for public health practitioners to address all of the health aspects at one time. DIS can facilitate STD and HIV testing, either HIV testing with syphilis cases And there are also opportunities to integrate services for syphilis testing with PrEP and HIV care. While that's not necessarily a DIS function, that is an opportunity for client-level integration. With DIS work and the follow-up of public health around syphilis cases, there are opportunities for assessment and linkage to care of PrEP on HIV negative and linkage and referral for the positives. And as well, opportunities for partner services with both. All of these efforts are very important and have similar application with the TB program and the work that they do with clients. And all of this can contribute towards the efforts to get to zero with HIV. So how are we doing with service integration? Looking at national data from 2015 that CDC has published, you can take a look at California numbers. On the side, you can see all early syphilis cases reported. And on the right-hand side, you can see those that are eligible for HIV testing and the HIV positivity rate. In California, our HIV positivity rate is 6% of the early syphilis cases in 2015. Where are opportunities to enhance HIV prevention efforts? There are opportunities to enhance efforts in actually conducting follow-up of all of the early syphilis cases that are diagnosed in the state. As you may note, California actually has a number of early syphilis cases that don't indicate follow-up. Our DIS workforce throughout the state is not proportional to the number of syphilis morbidity that exists within the state, and so local health jurisdictions prioritize case follow-up, and there are a number of cases that are set aside. Currently, follow-up is being prioritized for pregnant women in order to combat congenital syphilis increases that have been seen throughout the state. So here is an opportunity for HIV and STD programs to collaborate and work together, and for HIV programs to engage in this area, as many of the cases that are not able to be followed up are among MSM. As well, there are opportunities for HIV testing among those that are eligible. In California and nationwide. As you can see, nationwide, California falls into the middle in terms of the proportion of individuals eligible who are tested for HIV at 57%. How does it look in a California-specific scenario regarding HIV testing and linkage to care? With the syphilis cases that are in California, of those that are unknown status, 57% are tested. And of those tested, 6% are new positives. And of those, 55% have documentation of linkage to care. What this means in California is that we have some opportunities to enhance the client-level service, both in testing and in linkage to care. And as well, this may be an artifact of documentation because the data that are shown on this slide are coming from only the CalReady data system. And as many of you know, linkage to care may take a longer time, and in some instances, that data is not uploaded into the system. But nevertheless, opportunities to enhance efforts in order to improve HIV prevention outcomes. Looking more specifically at HIV testing and linkage to care, California had applied for CDC funding and then funded a handful of health jurisdictions to really put an emphasis on HIV testing and linkage to care with early syphilis cases. Alameda, Orange, and San Diego, which are indicated in the kind of orange bars, have received the bulk of the funding, and Riverside and Sacramento have also received some funding in order to evaluate their DIS HIV testing and linkage to care efforts. The green bar shown here represents the remaining California counties in the California project area, excluding Los Angeles and San Francisco. What you'll see here is that with increased emphasis on HIV testing and linkage to care, a higher proportion of individuals receive HIV testing within 30 days of their syphilis diagnosis. And when you look at the outcomes for the HIV testing, the highlighted red area is more similar to the proportions that are computed for HIV counseling and testing sites. Of those counties that had increased emphasis, 6.6% positivity was found with HIV testing of syphilis cases in the funded counties, 9.1% positivity in those counties that were funded for evaluation, and that's higher positivity than was found in those counties that were not focusing on this effort. And part of that could be that they are purposefully, the two funded counties are purposefully identifying high-risk individuals, bringing them to testing, and also bringing them to care. As you can see that the link to care data has higher proportions of clients linked to care among the funded counties. What this means overall is that there is great success in HIV prevention, in integrating services with HIV testing and linkage to care with early syphilis follow-up. In terms of re-engagement in care for early syphilis cases, there, as you can see in this graph, the majority of individuals were in care, which is the green arrow. For those 183 syphilis cases that were out of care, the linkage to care proportion does not look that good. Again, here's an opportunity for improvement in HIV prevention work, possibly improvement in documentation, but also looking at those individuals who are being seen for syphilis that are out of care may represent a high-risk population that is challenging to be in care. And what the syphilis diagnosis does is it offers an opportunity for public health to engage with that population and then get them linked into services and potentially assign them to a case manager in order to facilitate linkage to care when there's partnership at the local level. Other opportunities with syphilis cases are among MSM and PrEP for those who are HIV negative, and as you can see here, from 2015 to 2016, we've seen an increase in self-reported PrEP use. On to the disease intervention specialist bread and butter. What about partners of HIV positive clients? DIS nationwide are renowned for their partner services or contact tracing work. And partner services is a pathway for HIV prevention outcomes, particularly syphilis partner services and HIV partner services. They allow opportunities to identify individuals who are at risk, to get them tested and get them linked to care, re-engaged, or into PrEP. Most states routinely conduct HIV partner services with a surveillance-based model. California has been different due to laws and regulations. However, the current laws and regulations allow for proactive public health follow-up of HIV-positive individuals, and they allow for implementation of surveillance-based partner services. The Office of AIDS and STD Control Branch is supporting local health jurisdictions towards that end and recommends prioritizing new HIV positives, both acute cases and any stage of newly diagnosed HIV positive client for partner services follow-up, as well as those who have increased viral load, high viral load, and STD co-infection. This will allow for identification of individuals who may not know their HIV status and HIV prevention opportunities. California's current program has been more of a venue-based program, and the data associated with that program still shows a high yield for new HIV infection. Data from California project area, which spans up until 2013, has 400 elicited partners, of whom 44% were notified. That's 176, 77 tested, and of those, 17 were new HIV infections. That's 22% of new HIV infections, and that's a very high positivity. And that's without surveillance-based partner services. So we look forward to being able to implement a more proactive partner services program in the state moving forward. Who's doing this work in California? In California, only a few local health jurisdictions have dedicated DIS, CDIs, or disease intervention technicians. Many counties focus on the skill set, not the classification. And a number of counties have public health nurses, medical investigators, or other county staff who are conducting disease intervention work and have gone through the CDC's Passport to Partner Services training in order to do a robust job at partner services offer and elicitation. There are different models in different health jurisdictions for implementation of disease intervention work. Some counties are using integrated cross-trained teams of communicable disease investigators, where the same staff are following up with clients from the case report all the way through linkage to care. In other counties, CDI teams have different assignments based upon the knowledge, skill, and experience of the DIS and the complexity of the case. And in other counties, multidisciplinary teams work together where there are surveillance specialists, communicable disease investigators, and then linkage coordinators, each giving a warm handoff to the other. What makes success in this area and maximizes the DIS skill set is where counties are integrating client-level services, testing, linkage to services, PrEP or care, and partner services. What also is a recipe for success is data sharing, cross-training of staff, and utilizing staff strengths, looking at the competencies of each of the staff and making assignments appropriately. And then again, integrating program staff and assignments to better meet the program needs across the board, as opposed to in siloed areas where multiple staff may be contacting the same client. So overall, the success with disease intervention and disease intervention skill set is all about program planning with a thoughtful eye and an eye towards integration. Let me turn it over to Wanda.
Thanks, Romney. I'm going to go ahead and pick right up where you left off, and I'm going to discuss how the DIS role is really shifting and how programs are maximizing the DIS skill set for HIV prevention. Now, Because of everything that Romney just mentioned and the data that was shared earlier, many programs are using DIS to conduct linkage activities. Now, linkage to care models will differ based on the context of state and local programs, but I'm just going to briefly present a general flow to outline the activities associated with DIS conducting initial linkage services with newly diagnosed positives. As you can see here, there are 5 primary DIS HIV linkage to care functions. First, the patient is identified for linkage activities. Once that patient is identified, they're then assigned to a partner services linkage to care DIS. That DIS will then make the referral, make the appointment, send them to a linkage to care coordinator if they're not the linkage coordinator, and then they would confirm and document all linkage activities and provide feedback to surveillance. How patients are identified and assigned will actually differ by program. Now, in some cases, DIS might be embedded in a high-volume testing program center, or testing may be in health department-based clinics. Some DIS may be assigned to larger community-based organizations or private medical providers during testing hours, and in some cases, the patient will be identified by surveillance from lab reporting if that patient was not in care or not engaged immediately. Where those health departments actually have agreements with private sector testers, the referral may actually come directly from the provider, or a DIS will be called in at the time of a result disclosure. Assignment and prioritization for linkage will be determined by local program, but when it's not clear whether or not the patient is in care, the DIS will use all resources at hand to determine need for initial linkage or confirmation of linkage. And this is usually done by the DIS contacting the provider or searching the Enhanced HIV/AIDS Reporting System, EHARS, or other local databases. But from all available information, the DIS really is trying to determine if any special needs or considerations are necessary for a specific patient, because they really want to facilitate appropriate preparation for the initial contact with the patient. They really want to assure that this is a successful outcome with their patient. Now, prior to contacting the patient, the DIS will assure that they have all needed materials, forms, referrals, and other resources at hand. So this includes any program-required material, as well as anything deemed necessary from pre-contact information gathering. It's really important that DIS do kind of a pre-contact, that they really check to see if there's any referrals or anticipated issues that they might bump up against, because it's really important to ensure that it's a successful linkage. And so if there is, say, an issue with transportation or child care, we want to have those taxi vouchers, bus tokens, whatever we need, so that we can ensure it is a successful meeting with the patient. The patient is then contacted by means determined by the local program, and I do have to say that more and more programs are starting with the phone contact and interviewing as a more immediate option, as well as a more efficient and time-saving option for larger programs in geographical areas. Now, more patients can be assisted by phone versus field visits, and people in general are getting accustomed to communication by phone as well as text and email. However, the DIS, they use a number of different methods to notify patients. However, some DIS have stated that patients may be more likely to respond to a text than actually return a phone call. As in anything, DIS will ensure the patient on how their confidentiality will be maintained, and they also discuss the benefits of that patient being linked to care. And whenever possible, the DIS is going to make the appointment, assist with the patient getting to that appointment, and provide resources to keep the patient engaged during waiting periods for appointments. And this is like Romney was saying, we really want it to be a warm handoff. DIS aren't just providing, the patient with a pamphlet and say, hey, call yourself, but really trying to set them up for success and ensuring that it is, once again, a successful linkage. Now, in general, Linkage DIS are expected to confirm patient attendance to their first medical appointment, and this can be documented when the DIS maybe accompanies the patient, has contacted the provider, or they see in a database or maybe surveillance that follow-up labs have been ordered. It really is important to note that a linkage cannot be considered as done until the patient attends their first initial appointment. And I do have to say, unfortunately, sometimes that may take a while to get that patient to that appointment. So it's going to be really important that the DIS stay in touch and they periodically check in with the patient. And this also serves as another time or opportunity for that DIS to offer partner services to that patient, because while that patient is waiting to get to their appointment, oftentimes patients are wondering and thinking, who else could benefit? And this is another time to offer that partner services. Now, documentation may be directly entered into EHARs or other databases, and DIS may actually complete paper forms, which will in turn be shared with appropriate staff. I do have to say currently there are no standard national disposition codes for linkage to care. Usually program managers will direct their staff on how to disposition cases. The last of the 5 primary DIS linkage to care functions is to provide the feedback to surveillance. And as we all know that during partner service activities, we really often discover new and important information about our patients. Linkage activities is no different. The efforts will build more robust and accurate and useful surveillance data, as well as it'll make future linkage and re-engagement more successful. And it does help with having a complete and accurate understanding of the local and national epidemic. And as with all of the DIS work, they're taking every measure to assure that all patient information is securely managed. Describing how information is kept secure really might be needed, as we know when we're offering partner services. DIS often have to share with the patients how their confidentiality will be maintained. So those are pretty much the functions of linkage to care work and how programs are utilizing DIS. I just wanted to briefly talk a little bit about performance indicators and outcome measures for DIS conducting HIV linkage to care work. Now, although DIS are not traditionally responsible for program monitoring and evaluation, their work will be routinely monitored and directly impacts program success. So I just wanted us to have a general understanding around linkage to care work and those activities performed that most often are measured by HIV linkage to care programs. And really the ability to measure outcomes around linkage to care work serve to inform individuals and their programs. They can be good indicators of program success and weaknesses in part. Now, performance indicators, time frames, and outcome measures presented here are a depiction of the more common indicator and measures related to the work that DIS are asked to conduct. These selected indicators and measures are from California, New York, North Carolina, Texas State STD HIV Prevention Programs, as well as CDC. It is important to note here that indicators, timeframes, and measures set forth by individual state and or local prevention programs really supersedes what's presented here today. HIV linkage to care activities that DIS conduct and which are ultimately evaluated by their programs are likely rooted in the recommendations for HIV prevention with adults and adolescents with HIV, and this comes from the recommendation dated December 11th, 2014. Now, these next 2 slides that I'm going to show you is really just a summary of recommendations directly related to what DIS will be doing to support ensuring newly diagnosed HIV-positive patients are directed to medical care and treatment. These recommendations strongly suggest that DIS support patients starting HIV care within 3 months after diagnosis, although the new National HIV AIDS Strategy states 1 month after diagnosis. Recommendations also suggest that DIS should inform persons of benefits of starting HIV care and ART early. So DIS are really talking to patients and explaining the benefits of how they can live a healthy life, they can minimize the transmission to others, reduce their chances of advancing to AIDS, so on and so forth. It also suggests that the DIS will assess facilitators or any barriers that that patient may have to actually link into care. As I mentioned, we want this to be a successful linkage. We really want to get folks in. So they're really assessing what barriers they have and trying to work around those. The recommendation also suggests that DIS help persons, if needed, to enroll in health insurance or medical assistance program, and really now to go back to doing kind of public health detailing where the DIS are going to be required, or, you know, it might be a good idea to go to medical providers or HIV docs and really foster some relationships and promote prompt linkage services, as well as track outcomes of linkage services and provide follow-up assistance. Now, I do acknowledge that for some, these recommended linkage activities may be a little different from other partner services activities that, you know, DIS typically conduct and are responsible for. And so for these reasons, we all need to know what and when linkage to care activities are actually expected to be conducted and how their work and program activities related to this work will be evaluated. So once again, this is how DIS are expected to operate and the standards they are held to by most programs. These performance indicators and measures and standards by which DIS and their programs will be evaluated are based on best practices, guidelines, and policies from local and federal programs. Here they're saying that record searches should be conducted within 24 hours and immediately documented, as well as initiation of follow-up of HIV-positive persons for linkage to care services should always begin within 24 hours. Newly tested HIV-positive persons should be interviewed within 7 days, and those people living with HIV should be referred to care within 30 days. Any field visits should begin within 24 hours if unable to contact by phone, text, or email. So programs are saying if a DIS have a phone number, jump on it. Call those folks right away. However, if they can't get them on the phone or by texting or email, get to the field right away within 24 hours. All partners of newly diagnosed HIV-positive persons should be located, tested, and possibly treated within 7 days. And case closure should occur within 30 days or until the first medical appointment has been made and verified, whichever comes first. Case closure should be submitted to supervisor for review within 24 hours, and once a case is completed, that information should be updated in an electronic HIV surveillance system within 1 week. This last one, surveillance coordinators should follow up on all congenital labs and prenatal HIV reports within 48 hours. I know some programs have actually moved that to 24 hours because, like as Romney mentioned, nationally across the board we're seeing the congenital syphilis, a number of congenital syphilis cases, and so we are really, really trying to ensure that all these HIV clients or people who are living with HIV to make sure that there are no congenital cases for those babies. So generally, I do have to say the caseload for HIV linkage will be much lower than for syphilis and gonorrhea cases. HIV linkage and partner services may be more time and resource intensive. Therefore, accommodations for a realistic caseload is definitely necessary. Just to quickly talk about some quality assurance and quality improvement methods that we really want to focus on. You could cross-train your staff using the Passport to Partner Services program, which I'll talk about real briefly in a moment, and likely other trainings. You notice here we have the Office of AIDS and our CEBA network. The Office of AIDS offer a really good HIV partner services training that we really recommend that after DIS complete the Passport to Partner Services training, that they go to the California HIV Partner Services training, where they can learn about what forms are used, how to really work with people who are co-infected as well as living with HIV, and it goes into even more detail than we do in the Passport to Partner Services course. Also, in addition to that, the HIV Linkage to Care for DIS course that's offered by the California Prevention Training Center, our CEBA network, right now, it is an awesome course. It's really excellent, and it goes over more detail about what are some of the functions, and it gives the DIS great tools and resources to use to ensure a successful linkage with their patients. So all of these trainings are pretty straightforward. It gets everyone on the same page. They have a common understanding and skill set. Regular observation and feedback is always a good quality assurance, quality improvement method. A lot of times DIS are shadowed, or it will shadow an experienced DIS or supervisor. It's a good way to provide constructive and supportive feedback, and it's recommended. Case conferences, chalk talks, those are done regularly. We really want to maximize disease intervention efforts. So these are something that we really are recommending. And of course, review of records. How many of you are familiar with that? Yeah, I know. We are all familiar with the Cal Ready, updating all of our notes, making sure all of our field records, interview records, all of our documentation is complete, all of the dispos. So those are the QA and QI methods. I just want to briefly talk about Passport to Partner Services. The Passport to Partner Services training program is a blended learning program. Due to the current fiscal climate, health departments had to be mindful of how they spend their dollars, and many health departments had to make cuts, many needing to cut out-of-state travel budgets, and health departments could no longer afford to have their staff out of the office for 2 weeks at a time. Yes, folks, that used to be a 9-day training, but a solution was needed. So the Passport to Partner Services training program is a solution to the problem. Traditional disease intervention specialists who were required to attend a 9-day classroom-based course are now able to participate, as I said, in a blended learning curriculum. Now out of the office time for this type of training is only 5 days. And this Passport to Partner Services course was officially launched in April of 2013. Just real briefly, this is the structure. The Passport to Partner Services training is divided into 4 tracks, which are not only based on partner services job function, but really whether a provider refers patient to a partner services program or personally provides some aspect of partner services work. One can take online training only or opt for a blended program. The blended training program consists of taking 8 web-based disease concept modules, formerly known as the Employment Development Guide, or the EDG, and then 5 to 7 Partner Services Core Skills web-based modules, depending on the track. This online training is coupled with either a 3-day or a 5-day instructor-led course after completion of all online training. You'll notice here that the Passport to Partner Services is divided into tracks. Track A is directed toward medical and referring providers, offering an overview of partner services and support for referring patients to these services. Track B, that's intended for partner services providers who conduct partner elicitation and partner referral with limited or no partner notification. Usually we're seeing a lot of CBOs, community-based organization staff, attend this training. Track C is intended for partner services provider who conduct partner elicitation, partner notification, and partner referral for gonorrhea, chlamydia, HIV, but not syphilis case management. And lastly, the Track D, that's intended for those who conduct the full spectrum of partner services work. That's for the DIS. They do the interviewing, partner elicitation, notification, referral, syphilis case management, and visual case analysis. It includes 14 online modules, and you'll see here that it has a VCA E3 webinar series. We were doing the VCA E3 webinar up until August 1st of 2017. We're no longer doing that because we provide an extensive amount of VCA in the instructor-led course. However, I left it here because we're currently in talks with CDC about bringing that webinar back on an as-needed basis. So this is how the Passport to Partner Services looks. This really is just a colorful depiction of all the online modules, but really meant to highlight the second portion of online training, the partner services core skills modules. After the key disease concept, they'll take the introduction, communication skills, so on and so forth. So what do I say? Utilize us. Utilize the Office of AIDS and the STD Control Bench staff for TA and guidance while you're developing your program plans. Please, please, please contact the California Disease Intervention Services Training Center and the California CIBA team. We're here to assist you with capacity building, provider training, workforce training development, consumer engagement, you name it. Engage with other local health jurisdictions you've heard from on how they've actually approached challenges regarding linkage to care or routine testing or PrEP or PEP navigation. We want to hear from you, okay? Thank you all so much.
Wow, thank you, Wanda, and thank you, Romney. We are almost at the end of our time, but I didn't know if anyone had any questions. There were none being typed in the chat, which is where we're asking people to type them. And if we don't have any questions, that's fine. I do want to say that I think Wanda made a great point of utilizing your resources. And from what we've heard from Wanda and Romney, that there are opportunities for STD and HIV programs to work together. Really many opportunities, and that success, as we're seeing in a time of dwindling resources and a promotion of integration, Romney really pointed out that success is a way of starting to cross-train, to utilize client services, utilize data sharing, and integrating programs, and that there are skill sets, and many health jurisdictions are taking the opportunity to utilize and maximize DIS within their programs. And the same is true for HIV programs, that there are many skills that you've been doing and that those programs have as well, that if we can integrate and start to cross-train, it will be benefit, our clients across the board. We see that from the data, and we see that in the training. We're not getting any questions. I don't know if there's any closing remarks from anyone else, but I thought you did a great job, and I would thank people for both participating, attending, and Romney and Wanda for your presentations today.
Thank you, Linda.
Thank you so much.
Okay, thanks all. Then we'll sign off. Great job. This will be available. Everyone will get a copy of the transcribed webinar sent to them, and you can view it or share it at your, at your clinics as you see fit. Thank you.
Thanks. Bye-bye.